Hi, everybody. It's David Brysh, psychology teacher and counselor at APS Online High School, and we're here today to talk about depressive disorders, the group of disorders in the depression kind of area. We're trying to answer the question, remember, what is considered abnormal behavior? Last time we talked about anxiety disorders and that kind of group of or cluster of disorders, and then this week we're going to talk about depressive disorders and that group or cluster. So there are quite a few myths about depression, so I thought that we would talk about a couple today as a kind of a preview for one of your assignments, which is called myth busting. So one kind of myth is that depression is just an extreme form of sadness or of grief. And while it's true the symptoms are similar, the feeling inside is similar, depression is if you hear somebody who's been diagnosed with like major depressive disorder, for instance, if you hear them describe what it feels like to be depressed, it's a step or three beyond even sadness. It's a persistent thing that happens all the time for these people that feels like I've heard it described to me like a cloud is over their entire life all the time, that it's something that's always just beneath the surface. I hear that a lot. And in our society, we throw around the word depressed all the time. And, it's a natural feeling when, you lose someone close to you to go through a period of intense sadness, but you go through the period of intense sadness. That's the difference between sadness and grief and depression. Another common myth is that depression is just a feeling that anyone can just snap out of, if you try hard enough. And the reason why that's a myth is that depression comes from deep inside you and part of your core beliefs. So remember when we talked about in cognitive theory, you have these beliefs that are really difficult to change deep down inside, that you believe about the world, that you believe about yourself, that you believe about others. And it's from those core beliefs that the depression comes. There are other schools of thought that believe that depression comes from a chemical imbalance in your brain. And if a lot of treatments actually combine the two, we'll talk about that in a little bit. But if either of those things is true, that means that depression isn't just a feeling that's passing, that's fleeting, that you'll grow out of, that'll get better if you don't work on getting it better. So it's not just a feeling that anyone can snap out of, it's deeper than that. Another myth is that depression only occurs when bad things happen. And that isn't true. A lot of people that have been diagnosed with major depressive disorder, for instance, they feel depressed, they feel this mood no matter how their life is going. If their life is going well, then what they'll do is catastrophize things. They'll say that, well, this is only temporary, this is only fleeting. The good parts are just a prelude to something really bad happening. Another myth is that people dealing with depression can't feel happy, which isn't true. They'll report all kinds of times when they do feel happy for a time, but then they'll slide back down into the depression as soon as the momentary happiness is over with. And this one is kind of tied to depression and suicides. Typically, when people are really depressed and they can't get out of bed, let's say, and that sort of thing, then they're not very likely to commit suicide. When they're likely to attempt suicide is when their depression lifts for a bit and they feel a little happier and they feel more motivated and they can get out of bed in the morning. And that's when, what I was talking about before with the depression always being there inside of you, people still report feeling that depression deep down inside, even though they may appear happy, or they may be feeling slightly happier than they did the day before, more motivated, more willing to engage with other people and with society and that sort of thing. But that depression is always just under the surface. And the person starts to think, well, the depression will always be there and I'll never be able to get rid of it. and in a couple of days I'm going to start feeling depressed again. And that's when the real danger of suicide is taking place, is when the person is not at their lowest point, but coming up from their lowest point. That's when the real danger for suicide is. And the final myth that I have up here is that having depression means that I will be in therapy or on medication for the rest of my life. And that's not true either. There are a great many people who have been treated for depression successfully and who have been, for the most part, symptom-free. Even though depression can last for a long period of time, it can also be treated properly, and so it may be, maybe a person is dealing with it for a couple of years, but then through therapy and proper treatments, he or she can end up sort of, symptom-free for a long time. So here are some famous people who have dealt with depression. I don't know if you knew that these people dealt with chronic depression, but Abraham Lincoln was one of them. Another president, Theodore Roosevelt. Sir Isaac Newton, Michelangelo, artists and inventors. Charles Darwin was another one. And then some modern actors and actresses, musicians, like Christian Bale, the Batman. Louis C.K., the comedian. Alicia Keys, great artist, good piano player. And Beyonce, the superstar singer. All those people have dealt with depression, and many people would say successfully dealt with depression because their work, they're all famous, right? You know who they are. So their work has stood the test of time. Even though they dealt with depression, they found a way to make it work within their lives. So there are a number of depressive disorders. We're going to talk about a couple today, since this is sort of a short introduction to depressive disorders. The major one we'll be talking about is major depressive disorder. And the characteristics of major depressive disorder that I want you to remember is major depressive disorder, MDD, is 2 weeks or longer. Whereas persistent depressive disorder, sometimes you'll hear it referred to as dysthymia, and that is when the depressive mood is 2 years or longer. So this is like a chronic, that's what persistent means. It means the same over time. So, chronic depression is technically called persistent depressive disorder, according to the DSM-5. Sometimes you'll still see people refer to it as dysthymia. They used to call it dysthymia. It means the same thing. Like a significant depression for 2 years or longer. And then there's disruptive mood dysregulation disorder, which is sort of a subset of major depressive disorder and persistent depressive disorder. And what I want you to remember about disruptive mood dysregulation disorder, DMDD, is the disruptive part. This is when instead of the depression manifesting in sort of a mood where it's difficult to get out of bed and you're feeling down and you'll see a lot of people, with their shoulders slumped and their body drawn inward. Disruptive mood dysregulation disorder is characterized by irritability and lashing out at people and that sort of thing. So a lot of people find it surprising, I guess, that disruptive mood dysregulation disorder is related to depression, but it is. The reason why people are irritable is because of the feelings of depression. So here's our diagnostic criteria. We're going to focus on major depressive disorder because it's most commonly diagnosed. And the first part of it is that there are 5 or more of these symptoms. So you need at least 5 to be diagnosed with major depressive disorder. These include depressed mood most of the day, nearly every day, diminished interest in normal activity, so you might have liked to do a sport before, or you might have liked and enjoyed drawing, or you might have been interested in going to the movies a lot and that sort of thing. What you'll see is that people have this marked change in, you used to like doing something, and then all of a sudden people don't within a month or two. And that's a major sign of depression. There's significant weight loss or weight gain, because people feel like their appetite is not there in terms of the weight loss. Or if people are gaining weight, they feel that that helps lessen their depression and lessen the feelings of hopelessness and that sort of thing. Eating does. There is insomnia and hypersomnia nearly every day. So you're either sleeping too much or way too little nearly every day. That's another sign of depression. It's throwing off your sort of bodily regulatory system. It's part of the reason why you're not interested in normal activities that you used to find pleasure in. You feel fatigue nearly every day. A persistent feeling of being tired all the time. There's feelings of worthlessness and excessive and inappropriate guilt over things, a lot of times over things that people can't control. So that's a very common one. There's diminished ability to think or concentrate. So this obviously would affect people in school or at work. And there are recurrent thoughts of death, suicidal ideation, or their suicide attempts. So if you have 5 or more of these symptoms, a person could be diagnosed with major depressive disorder. And then there can't be any manic or hypomanic episodes. These are more commonly associated with bipolar disorder. So if you see these in a client, then the clinician is going to say that a more appropriate diagnosis is probably going to be something in the bipolar domain. But manic and hypomanic episodes means that somebody is, instead of depressed mood, think of the exact opposite. Somebody is really amped up, and people find that they're more productive, that they're happier, they talk a lot faster, everything is happening, everything's totally awesome and everything's great, and people are, like, during this time they work a lot. There's all sorts of symptoms that go along with mania and hypomania. But that's sort of like the opposite of depression, if you can think of it that way. A clinician also has to make sure that symptoms are causing what, remember we talked about clinically significant distress in social, work environments, or school environments. And symptoms are not because that somebody's ingested a substance or because of a medical condition. And remember, shorter time periods are major depressive disorder, while longer time periods, 2 years typically, is the persistent depressive disorder or dysthymia. So here's a case study. So take a second to pause me and read the case study and think in your head what you believe this person should be diagnosed with. Should we give this person a diagnosis of major depressive disorder? Pause me and I'll come back and talk about it a little bit. So Alicia here, even though she finds it difficult to get out of bed in the morning and is finding difficulty eating, even though she says that she's always depressed, she's only been feeling this way for a month. So that should be one kind of warning sign to you. If you were a clinician, you hear just for a month, you would ask the client, well, what happened in that month? Did you see what happened? She broke up with her significant other. And she's been drinking. Both of which could be causing the depressed mood, rather than, a diagnosis of major depressive disorder. And then this last sentence is also important. She recently lost her job because she found it difficult to make it into the office in the mornings. Now that could be what we would consider significant um, that would be clinically significant problems in your life, right? But the problem is those clinically significant problems could be caused by the drinking, could be caused by the breakup, not necessarily by major depressive disorder. So this one's an iffy one. Then here's case study number 2. Pause me, take a second or two to read this, and then play me again, and you can hear my take on this one. So let's go through what we have in this case here. Freddie is an 18-year-old high school senior. He's reporting that he feels tired every day, and he's often sleeping 14 to 16 hours a night. That would be the hypersomnia, right, and the fatigue here, feeling tired every day. He's missed first and second period at school 21 times over the past 2 months. That's a lot. So we have some clinically significant disruption in school, I would bet. If you dig into that, I bet his grades aren't too good. Either of those classes at least. He was a starting midfielder for the soccer team for the last 3 years, but he had decided not to go out for soccer this season. That should be kind of a big indicator for you too, because that was something that he enjoyed a lot in the past, but now all of a sudden he's deciding, that he's not getting enjoyment from something that he used to enjoy a lot. And he's reporting that he's attempted suicide twice over the past year, with pills and then with a car. So all of these details here point to major depressive disorder. So if you thought to yourself, hey, this person was a better candidate for major depressive disorder than Alicia was, then you're on the right track. So that's good to see. Let's talk about treatments. On the therapy side of things, there was a cognitive behaviorist, Aaron Beck, who did most of his early work about depression. And so, as he was coming up with cognitive behavioral therapy, I think you remember me talking about this in the first part of the year, that he focused on people with depression, and that's how he came to his theory. He started off as a psychoanalyst along the lines of Freud, in that kind of school, and then he learned that his patients, he called them patients, we call them clients now, but the ones who had depression weren't responding very well to psychoanalysis, so he came up with another way to work with them, which ended up being cognitive behavioral therapy, this stuff here. And so he tends, if you read his books, and his daughter now, Judith, she runs the center that he had set up, and so he works on clients' core beliefs and automatic thoughts that have to do with guilt, with inadequacies, with trauma maybe. So it's, in the talking therapy, it's all cognitive behavior. And what you're trying to do as a therapist, as a cognitive behavioral therapist, is get at the core beliefs of the person and figure out why the feelings of worthlessness and hopelessness, why those feelings are there. What's causing them. It's some sort of, to a cognitive behavioral therapist, it's some sort of cognitive sort of misprocessing. You have a faulty core belief about yourself, and about how worthwhile you are. That's leading to everything else. And then there's drugs. I'm sure you've seen ads on TV for some of these things. The general type of drug is an antidepressant. There's maybe 4 or 5 different kinds of antidepressants. The most popular are called SSRIs. There's the acronym there. They stand for Selective Serotonin Reuptake Inhibitor. And it's a bunch of fancy words meaning that it regulates the serotonin levels in your brain. Serotonin is a chemical in your brain that is linked to um, mood. It's most commonly prescribed, like it says here, and the reason why it is because it's not as powerful as some of the other ones, and it has fewer side effects. So most doctors or psychiatrists start with the SSRIs before they move on to some of the more heavy kinds of drugs. So if you've seen commercials for Cymbalta or Effexor, that's what we're talking about. Really, though, most treatments for depression are a combination of maybe an SSRI and psychotherapy. But the APA, the American Psychological Association, says that if you are taking antidepressants, you should be also doing psychotherapy. So you shouldn't just go to your doctor and say, I'm depressed, give me something for it. And then your doctor just, hands you over some pills and then, everything's cool. It should be a combination of both. And that is a short version of depression, and hopefully it answered our question here, what is considered abnormal behavior, with all of our diagnostic criteria right there, and what it looks like to have major depressive disorder. This doesn't quite rise to the level of major depression, I would argue, while this study does. Okay, so you guys out there, you have a good week, and of course, as always, let me know what I can do to help explain, help you understand more about depression, and help you distinguish between what is sadness or grief and what is actually depression. All right, thanks for watching.